to the class.
Okay, hi everyone. We are here with our Pride Edition Pink Table Talk this month, and I'm really excited. I have some really close friends from like various parts of like my life here, and so I'm really happy to have this amazing group. My name is Haley Brown Buxton Punch. I have another Buxton Punch here with me today, so that's exciting. Again, we are here representing Touch, the Black Breast Cancer Alliance, and the For Love of My Girls campaign to really shed light on Black breast health and what we can do to really bring attention to the LGBTQ community. And I'll have Dr. Candace now introduce herself, and then we'll do some other introductions.
Hi, everyone. I'm Dr. Candace Thompson. I'm a breast surgical oncologist and really excited to have this much needed talk today.
And my other Buxton Punch here.
Hi, everyone. I am Jalen Ayana Buxton Punch. I am a queer activist, a project manager in the nonprofit space, and really just a lover of all things Black-centered, women-centered, people-centered that amplifies and tries to really dissect what makes us traditionally marginalized and could make us centered in the work that we do.
Yes, and Uza.
Hi, everyone. Uzo Sameka, member of the Touch family. And I'm going to second that, Jalen, Afro-Caribbean queer woman myself. And I just want to do all things Black, queer, and women-centered. So happy to be here.
And Isis.
Hi, you all. My name is Isis. I'm also a queer team member of the Touch organization, and I also am about all Black things or all women-centered things as well.
Love it. And Nat, I'm so excited that you're here.
Hey guys, how's my mic? Am I
good? It's good.
Awesome. I'm Nat Brown. I'm a lawyer. I do practice corporate transactional law. And I wish I had a nice little intro and all the things that you guys just named, but I think just as a general matter, I'm a humanist, and I think it's super important to center Black issues, and in particular as Black women. That's and unfortunately overlooked and often kind of underrepresented group when you talk about health specifically. And probably obviously in many other ways. So this conversation is near and dear to my heart. And so excited to be here.
Totally. And like Pink Table Talk, why we have it is really because Black women under 35 get breast cancer at 2 times the rate and die at 3 times the rate of white women. And so this is a space for us to really just shed light on our experiences in healthcare. And that's kind of what I want to bring, to the table today. But first, I want to ask everybody, how are you celebrating Pride this month? Are you celebrating Pride? What are you doing? Anything fun? Personally, the Touch team will be at Pride New York Festival this Sunday. We'll be sharing information and giving out our really fun beads we made for Mardi Gras. And we're like, this is like great festival item thing. So we're gonna do that again here. Last year we did the parade as well. And so we're really excited to be back here in New York. Still missing SF Pride because that's my favorite one, but happy to be New York Pride. But how are you guys celebrating Pride this year?
All right, I'm definitely gonna kick it off. I am anxious. I know Haley said they were happy to be in New York Pride, but I'm just gonna act like I didn't hear it say next to it. I am a proud head marshal of Dyke March this year. Please join us on Saturday, kick off at 5 p.m. Pride is a protest, so as much as I love to celebrate, kiki, party, we will do all of that at the after party. But it is a protest, so our theme this year is Dykes Against Genocide, and I am making sure to think of, to honor, to amplify my Palestinian sisters, my Ugandan brothers and sisters, my sisters in Sudan, of course, my sisters experiencing violence in Haiti right now, in Ethiopia, in Myanmar, in Ukraine. I can keep going. That's the issue. So making sure to really center not just the kiki and the pride and the party and the beads, but also the purpose of why Pride was started, which it is a protest, it is inherently political, and I am celebrating Juneteenth, Pride, all of it all month long.
Yes.
Uh,
And
If I- Okay, awesome. You know what? I haven't yet been able to hit a Pride parade up or anything like that, but I think I've been spending this month with very close friends in the community, and ones that I think have had somewhat traumatic histories on their sexuality and just in general being out open and, you know, happy, well-adjusted human beings. So I've really just been centering people and folks that I know just need that like love, extra attention, and you know, around the time where I think it's easy to remember some of the things that you've had to overcome in this moment. I think Jordan was talking about this being a protest moment, right? Like, you know, starting even from home, when people are not willing to accept you, you're in a protest in the space that should be the most comfortable to you. And so you learn to not center home and not feel comfortable in your own skin and just like where you're supposed to be, you know, at peace and have joy. And so I think it's really, really important to remember those friends who've had those experiences and shower them a little extra around this time.
Amen.
anyone else? Yeah.
Well, with me, I've been taking the time this month to talk to my fellow community members and have the conversations upon this time and being accepted and just our journeys working through accepting ourselves as well as others accepting us as well. And I've been going to some boutiques that we have here in Austin and gathering some small things like stickers and socks and shirts.
Yeah, sure. Think about where you spend your money is a huge way to support, you know, the things that we care about. So I love that. Yeah. Oh, who else?
I wish that I was in New York celebrating Pride, but I will be here in San Francisco. I'll probably wander out to the festivals and the parade and everything. And celebrating Juneteenth, just being with loved ones and everything.
And Lisa, what about you outside of your obligated work?
It's great obligated work, but yes, so I will be there on Sunday. And I really haven't done a lot of gay things this month. So I'm kind of like, okay. But at least we'll have we'll have Sunday. I'm excited about that.
Well, I want to share something. So we go to this major cancer conference called ASCO every year. And this was the first ASCO where there was like a lot of programming for the community. And I wanted to quickly bring this to the forefront and share some information that I think is relevant. I mean, it is definitely relevant. And kind of start us there so we can understand again, because although we really focus on Black breast health, it's good to like ground us in the fact that like Black breast health is real because Black breast cancer is real. And so just going to share this and take a second for us to look at this information here. So this was, you know, an abstract that I thought was really important. And so hopefully the audience can take a second to read this, and I'll read a couple of things right now, but most LGBTQ plus patients, 80% reported not receiving appropriate preventative cancer screening, with top barriers including provider did not mention cancer screening tests, 40%, and did not have a healthcare provider, 28%. Additionally, only 24% felt at least moderately comfortable disclosing their LGBTQ plus status. Inclusive measures that helped patients feel most comfortable included care teams sharing, displaying their own pronouns, 39%, making public statements of support, 43%, or wearing personal items indicating acceptance, 39%. Of those who did disclose their identity, only 50% of gender expansive patients reported consistently being referred to by the correct names and pronouns. Importantly, patients reported that only 34% of their partners/caregivers felt welcome at appointments, and only 4% felt respected by the care team. So I'll stop there for a second so you guys can just like take that in. And I want us to think, and reflect on this. And the conclusion here says this study offers insights into experiences of LGBTQ plus patients and confirms disparities in care are real and pervasive. Ongoing education and inclusion efforts can help create a safe and welcoming environment, enabling equitable care and improved outcomes. So just everyone take a second, and I'd love us to all just reflect on this and share, what are your thoughts after reading this, hearing this? Is this something that you can resonate with? Have you heard some, things that are similar? I know I have. So I'll give a second to think and then share. Feel free to chime in, anyone really, because I know this is heavy, but also like very, very real for the community.
Thank you for sharing this, Haley. I think this is a great abstract that sort of demonstrates the issues that we have within the within healthcare, especially as providers. I think it's really important, especially while in training, to see providers who demonstrate the traits that are important in order to be inclusive of all patients. I think it would be interesting to, I have some questions regarding the article, but I won't bore everyone about that. But I think this is a great article.
I really resonate with a lot of what the article is not only pointing out might be some of the more commonly or more pervasive issues within trying to seek healthcare within the queer community, but also given the high rate of incidence when it's talking about receiving appropriate preventative screening, right? That's really indicative of the same trends that the National LGBT Cancer Network has recently published. In August of 2022, they were saying that LGBTQ plus people are more likely to have a cluster of risk factors that contribute to increased cancer incidence and late stage diagnosis. And these factors include delayed cancer screening, alcohol use, potential HIV acquisition, higher levels of smoking, higher levels of HPV. And when you really get down and stratify it, lesbian and bisexual women and have higher levels overall of breast cancer, colorectal, skin, cervical, endometrial, and ovarian, whereas men are at risk for anal and often prostate cancers that are just going unscreened and undiscussed within those communities because of stigma, because of lack of gender affirming language when speaking to it. And I just think these problems are so pervasive. It seems that, no matter what your social determinants are, how much education you have, where you live, to be queer and to be Black is also to be at risk of so many health and so many comorbidities that I just don't think are often enough given a fair conversation. So I really appreciate this abstract and bringing some of the stats to us so we can hear just how alarming and pervasive these issues are.
Yeah, piggybacking off of you, Jalen, Kaylee and I were at a conference today, and a lesbian woman spoke, and she was saying being lesbian doesn't inherently make me more susceptible to cancer, but it does increase my stress levels, which affects my body and can make me sick because of the discrimination that I face, especially when I'm trying to receive proper health care. And I can definitely resonate with these experiences mentioned in the article as well. I mean, for the longest, it took me forever to acknowledge my sexual orientation in the provider space because I was afraid of how that would affect my care. And I know that so many can relate to that. So it's unfortunate, and we have a lot of work to do.
I agree. I think as someone who's not really, I don't think I've had the particular experience of being uncomfortable, being, just myself and or sharing with people about, my sexuality or whatever, answering these questions. But that's like a very, I think, I don't want to call it privilege, but it's a state where it's really easy to overlook some of these issues. And particularly, I think the thing that always stands out to me is like stress, right? Like the stress of not being able to feel comfortable about speaking up, like the stress of being worried about seeking healthcare, which is, I mean, I'm sure you guys hear this all the time, like I do. One of my good friend's favorite saying is, you know, health is wealth. And that is so critical, right? Like it's so important to be able to know what your status is, and that's across the board, whether it be things like HPV, HIV/AIDS, whatever it is, or even just basic, you know, health issues. I think the article named a few that was just interesting to hear, because you don't think that people are generally, I think, you know, coping in ways that are specific to health issues, if that makes sense. Usually think of coping as like, you know, I'm coping with the fact that I can't speak up. I'm coping with the fact that, but like the idea that you are also coping and using, you know, probably deleterious kind of, you know, coping mechanisms that injure you because of the stress is like a crazy cycle to be in. And so that really just stands out to me, because it's just such a shocking state to be in, that it's something that I think does need to be amplified, and people do need to kind of be aware. And I think that kind of goes back to what I was saying earlier, and just like, what am I doing this month, which is just like being a present party. And that alone does make a huge difference for many people who just literally can't like say it or be open or whatever is on their mind. And so I think that's at least one way to be present. But I think the most important is exactly why we're gathered here today, which is, you know, to spread awareness and allow people to kind of have a different lens into the experience that they may not have any, you know, touch point to.
Yeah, no, I'm thinking like, let's like really think about when you go to the doctor's office, okay, and you like are just in that experience and in that moment. What are all the things that you notice that, you know, a cisgender person might not notice? You know, like what are all of those things? Is it the labels on the bathrooms, the signs, the everything, right? So can anyone speak to those experiences, and maybe even Dr. Candace, from your experience of being an HCP and being in so many offices, you know, what things do you see that we could change or need improvement, or things that have been successes?
Yeah, I can definitely start. I mean, the first thing that came to mind when like seeing that article as well is during residency, for general surgery, we have to like rotate through trauma, so like doing trauma surgery. And I just remember this one time we had a patient come in, and it was a transgender patient, male to female, and everyone around like the trauma bay was like, I don't know how to address this person, like yada yada. And I'm just like, well, maybe we should talk to the patient. So I talked to the patient, and I was just like, hello, like so and so, how would you like to be addressed? And like talked to them, looked at them in their eyes, asked them what was going on. And it's like, these things are being taught nowadays to us as providers. So I think there is a change for the better, and people are being more understanding, but there's definitely like still others who may be slower to sort of understand how to address people who are different from them. So I think, yes, there are a lot of obstacles in the way when going to the doctor's office. I think it is being addressed on a larger scale. Obviously, it takes time. But there are providers out there who do care and who can like speak with people from any kind of background. I don't know if that helps answer your question.
It definitely does. It gets to it, Dr. Candace, because for me, from a very young age, I have always looked for what I consider like accessibility in my provider's office. So if there were no Black figures in the drawing as a kid, I knew that was my last time in the waiting room. If there were no rainbows, if my provider did ask me how I wanted to be addressed, which for the longest time, really manifested in ways like simply as young lady. Yeah, no, that didn't fly long either. And I didn't have the terminology at the time to figure out what it was, but it was just this lack of gender affirming care. It's this lack of culturally responsive care, right? Where at the end of the day, sometimes it's not always spoken, sometimes it's not always explicit, but when someone feels unfamiliar caring for you, you also begin to feel uncomfortable as a patient, as if there might be something different about you. So I found going to places like Whitman Walker in DC, which for everyone in the audience, if you're in DC, Whitman Walker for over 50 years has been the leading queer and medical provider in the region. They are absolutely phenomenal, and they provide holistic services from mental health to primary care to individual treatment plans that include pap smears, OBGYN services, even if you might be transgender. For me, being in spaces like those and seeing the arrays of which the healthcare could be tailored to my needs, or better yet, I could be treated almost as if, equal is not the right word, but almost as if there wasn't a discrepancy
Like a
in
human.
some of the questions. Yeah, and some of the questions for me definitely changed. I'm curious for Isis or for Uza, have those questions when you disclose, oh, I'm queer to your provider. Do they stop collecting your urine? Which means, of course, it's not just pregnancy they're testing for. You might miss the UTI or the yeast infection, which happened to me several times. Like, what are the ways in which it changes slightly or not slightly when you have disclosed or have not disclosed, I guess is what I'm curious on, because I now only go to queer and Black providers for that reason. So I'm a little biased.
With me personally, I have yet to disclose to a doctor, if I'm being completely honest, only because of how the medical field is. You kind of just don't know how they're going to be receptive to that information. But that is something that I do want to do more comfortably moving forward, because I am queer and I would like to get the right, I don't want to say equal, but the equal treatment that other patients would also receive.
No, thank you for sharing that, because I'm sure that there are a lot of people in that moment, you're not the only one.
Yeah.
Yeah, and Isis, you're also in Texas. So
Yeah, it's not great.
yeah.
Yeah, still
Um,
working here.
yeah, as I said, it took me a while to disclose that. And I have then started making the shift like Jalen to find Black queer providers wherever I can in any specialty. I haven't found that it's made it difficult yet. So that's good. But I also thought about one of our friends, Megan Clare, who was also at the conference, would share today. And she said something about not at being asked to then be corrected, something along those lines, right? And then it made me think just now about, instead of yes or no, start asking open-ended questions as providers. Because that leaves us more room to speak to how we want to be addressed and how we want to have this conversation, how we would like our treatment to go. So that just came to my mind, but I think that would make just for a better experience overall if we started asking as providers open-ended questions.
She also said, I'm glad that you brought her up, because she also said today, shout out to Share Conference because it was great. But she also said that when you don't know something, right, to ask, then hear, how someone wants to be addressed, or that open-ended question, right? And then repeat the corrected version. And I thought that was really powerful, right? And as a teacher, it's gonna stick more if you do repeat these things, right? And so I thought that was really useful tool to that we can all implement tomorrow, right? But yeah, Any other thoughts?
I do think it's interesting that the default is assumed straight, if you will, like the default is heteronormative, so it would be a disclosure. And I find that very interesting. I also find it interesting, I guess, that the default is cisgender. So if you pass, like I do, I am non-binary and I pass all the time for being a cisgendered woman. And yes, my pronouns are she, they. Most days I feel really femme, I resonate with she, that's great, but that does not exclude the they portion of the days. And I find it so interesting when that default or that mechanism relies less upon like learning about or understanding and more about assuming, because I guess that's where some of those disparities in care might really lie. It's like these assumptions that are not universal. And so I guess for everyone in the audience, if you, whether you disclose it to a provider or not, I hope you disclose it to friends, if possible, or family who can help advocate with you for whatever you might be looking for, whether it be a mental health professional or a primary care physician, or perhaps a women's health, provider, whatever it is. Just because, yeah, when you get there, that is another hurdle in itself.
And I think it's really hard, especially when you are dealing with cancer specifically, because even if you do find doctors that you do trust, for various reasons, because of your race, identity, all of the above, when you need nuanced care, you're like, then it's gonna be even harder to find those doctors that you can identify with in those ways, right? And so it's like, I feel like that's that next hurdle that becomes really, really tricky. Because you need those doctors even more now, and they're looking less and less like you as you need them like more. And so that's like a really hard part of this as well. Yeah.
I have a question, I guess, like as a provider, like personally, I see all of my patients as humans. I'm not one to like judge anyone on anything. When coming to a provider, besides like looking or seeing commonalities in yourself, are there other areas that make you feel comfortable coming from the community?
I'll kick it off. I know for me, if a provider walks in the room and introduces themselves with their pronouns, I immediately introduce myself with my pronouns as well. If they have gender expansive terminology, it's not just binary terminology. I incorporate it and feel more likely to share it as well. So I think one of the main barriers, besides just being friendly, being receptive, and being Black is also showing, I guess, that double cultural affirming moment. That is that sometimes there are discussions, just small language shifts, going from do you have a boyfriend or girlfriend to going from do you have a partner, going from do you have a husband or wife to spouse. Like they're just small subtle shifts that make a huge difference in the way in which I feel viewed, and also I am viewing that interaction, if I'm being honest.
Makes sense.
You asked that because I'm now thinking about my last primary care doctor and why I had such a positive experience with her. And it was because actually, and this is something for me to now think about as I go to find another one because she retired. But it took multiple visits for me to see that I enjoyed her, because it was the fact that she remembered things about my life and she like kept up with things, you know what I mean? Like I didn't have to go and explain that thing again. You know, she kept in touch and she asked questions because she remembered things. So I wasn't just like many of one patient, you know, like in one patient, I was like someone that she cared about, and whether that was true or not, you know what I mean? But like she just knew details that made me feel as if it was a personalized experience, you know, which I think is great.
Of course, understanding how the medical system works and knowing that sometimes these appointments are 15, 30 minutes, I think start with sitting down, walk in the room and sit down. Because I know I get anxious when you're standing above me and I'm sitting on the exam table, or I'm sitting in the chair. Sit down with me and then introduce
A
yourself.
lot of doctors standing above you when you go into.
They'll come in and then maybe it's a quick appointment, not standing up, maybe not up right above me, but like
Okay.
they're standing, maybe they're taking notes or they're on their laptop, or they're just like not
Oh,
to,
wow.
they don't feel present to me.
Yeah.
If you came in and you sat down and you looked me in the eye, then I immediately start to feel comfortable. And then if you maybe tell me who you are as a person, not I am so-and-so, I do this because I know I know your doctor name and I know your specialty already. So maybe tell me a little bit about who you are as a person so that I can then share who I am as a person. I think that would help me.
I was actually just gonna say something extremely similar, which is just, I mean, manners in general seem sometimes to just be completely lost, but like bedside manners, right? Like bedside manner matters, right? Like that, I think just having a basic understanding of how to approach another being who's in a situation where, you know, you walk in, it's this clinical space, you know, that if it's one of those doctor rooms where it's got that like sheer paper on the, you know, and you sit down, it's all uncomfortable. And it's like, you know, anything that you can do as another human being who's engaging with a patient, right, to just make them feel less awkward in that space, I think goes a long way. And it's crazy to think that something as simple as sitting down is like, you know, an item that like you can check off as like very often that's not the case, right? They'll come in, they've got the chart, they're like moving quickly. And I do recognize too that a lot of times the appointments are very quick. And there's, you know, the whole haste of the general kind of like, you got to get to the next person, you got to get to the next thing, or whatever it might be. But I think the bedside manner goes a really, really long way.
Yeah, I would have to totally agree with that as far as being welcoming and walking in there, being open rather than just assuming, because assumption can really throw things off. Openness, you actually hear somebody make that comfortability to actually share information with you to where you can excuse me, you guys, my allergies are so bad, to where you can actually hear what the patient is going through, and then they'll actually be open to tell you things rather than being closed off because that first interaction wasn't very good. Yeah.
Yeah, these are all interesting. It feels like it's like this doesn't feel specific to being in the LGBTQIA plus community. It's like things that we all want. So
No, it's totally true.
Totally true. And I also think there are some great moments that I have had from these queer providers who have pointed out to me when there might be endemics happening in the queer community around me, who have, you know, emailed me or called me to be like, hey, do this extra screening. I'm seeing an increase of patients with X, Y, and Z. I think sometimes it is great to be treated as a person, to be treated as equal, and to hold that as true for all types of healthcare and all types of services. And I also think that what makes being queer and being Black such an intersectional kind of risk, almost a higher likelihood of some of these comorbidities, is that there are things that need to be additionally done that could be missed without that level of training, without that level of knowledge. And there are assumptions that, you know, are made, unfortunately, that do lower the amount that we are tested for some of the things compared to our counterparts. And so for me, just finding that delicate balance of like a doctor who treats me as human and also who knows that the human they're treating is a non-binary Black person who is proudly identifying as queer. I think that that is something that is equally as important, that both and that memorizing, that sitting down. It's very interesting.
Yeah, and will make you ultimately invest in not just sick care, but also health care, right? And so like, how many of us actually go to the doctor when something's not wrong? You know, and I will admit that I'm at fault for that, you know, it's really easy to go when something's wrong and not always go just for those normal appointments. And even making appointments is hard, and finding the time, and then I make them and then don't go, right? And so it's like, I've been advising everyone to keep their appointments. I think that's generally good advice, but it's not easy to do that. And yeah, so I have another video to share that I'd like to share with you, but any other comments first? Okay, cool. Well, Dr. Keith Crawford is a good friend of ours. He specializes in prostate cancer. And he was actually on the Doctors In episode that my mom had earlier this week. And so I wanted to share a piece of their like literally their show also on Black Doctor, as so if you are on Black Doctor right now and can see, go watch this show too. But I'm going to go ahead and share this video because I would love for us to take a quick look and then also reflect as a group on his comments here. Can everyone see this?
in the prostate space, but what are you seeing?
Well, look, I wanted to step back and say that for the audience to understand that Touch and Finn, we want you to be your unapologetically you. That's what we want you to be.
Yeah.
We want to bring awareness to cancers and for you to get the best care that you possibly can. So you need to be your unapologetically you.
Yeah.
And then add on identifying that purpose. Now, what's coming up is there's the stress. There's a tendency to kind of group the LGBTQ community together and as one. And what you have are groups that are together, but then there are groups that are double marginalized. And those double marginalized in the transgender space are under a tremendous amount of stress. Matter of fact, CDC came out with a report stating that the transgender population have a tremendous amount of loneliness and depression in that space. And so, because you're double marginalized, no matter what, at the end of the day, you're Black. Now, you're Black, whether it's in the cis population or in the trans population. Except for in this case, you may not have any support. So what's interesting is this, in the breast space and in the prostate cancer space, the treatments that are used are treatments that influence hormones, your sex hormones. So an interesting point that a lot of people don't talk about is, if you are a trans woman, will you get prostate cancer? Now, interestingly, what is unknown to an extent, that if you are a trans man, will you get breast cancer?
Are you,
And
Misty, are you seeing this?
you see, and so these folks are out there, but there's no one talking about it.
Right.
You're seeing it, but we're turning the light on in the room. And then if you're Black, you got 2 hits. Now, what's interesting about the prostate cancer space, I mean, in this case, trans women, I may have made a mistake and said trans men, but trans women can get prostate cancer because they still have their prostate. What we don't know is this: if we treat you with gender affirming hormones that are similar in function as the androgen deprivation therapy for prostate cancer, would that suppress the growth of the cancer? So that means that a lot of trans women may end up with advanced aggressive prostate cancer that's resistant to conventional treatment. So have you heard that before?
No, this is my first time.
Yeah. And then if we
And
start,
the medicine that you treat prostate cancer with
Mhm.
could make the cancer worse.
No, see the medicine that they're gender affirming hormones. So
What's a
if,
gender affirming hormone? Talk to me like
so
I'm.
say for example, estrogen like hormones. So if you were born at birth, you were classified as a male. Why? And you're transitioning into being a woman, you will receive hormones, estrogen hormones that help you transition. Now, if you have prostate cancer, and so the estrogen block the testosterone.
Right.
Okay. The flip side, if you have prostate cancer, your treatment options are compounds that block your testosterone. So if you overload your body with estrogens, overload your body so a cis individual overloads their body with estrogens, and that testosterone level will drop, and you start to transition in. But the problem is when you have prostate cancer, it's a similar mechanism that's used to treat the cancer so it doesn't grow. You want to shut down the effect of testosterone. And so what happens is when you have trans women who they still retain their prostate, but nobody talks about that. So if you're Black, if you have African ancestry, you're at risk at prostate cancer. So that means you should be talking about prostate cancer at age 40. But there are people who transition out, transition over, and become women.
And I've never heard about this.
And never heard about it.
So I'm gonna pause there. It's we can listen to this whole thing, and I invite everyone to go back and watch this video. Seems like we lost some people to some Wi-Fi issues during that, but still, I'd love to hear some reflections. I know Dr. Candace, you're probably slightly nerding out to some of this as well, because I know you. But I think that, again, this is a chance to just like shed light on these topics, right? Because I think it's really important to discuss
Yeah.
what our future problems could be in this space, or what our future issues could be.
Yeah, and he brings up a very important point for transgender male to female. But in addition to the prostate cancer risk when taking estrogen, the increased levels of estrogen can also increase the risk of breast cancer as well, even though it's male to female. Males, we know, can get breast cancer, and we know the most common type of breast cancer feeds off of estrogen. So there is a risk of breast cancer in those individuals as well. We don't currently, per the NCCN, for those who were assigned male at birth, we do not do routine testing on those individuals who are taking hormones when going from male to female. So we're mostly relying on what we would rely on if they had not gone through the transition, which is just physical exam. So any males transitioning or on estrogen hormones should check their breast each month to see if they feel any lumps in their breast. In addition, for females to males, I've taken care of a few patients now who have had mastectomies. and or top surgery. And sometimes in these situations, not all breast tissue is removed because the goal is to have a sort of aesthetic look where it like looks like pecs instead of completely flat, where it would be like a flat mastectomy. And there can be breast tissue that's left behind in that situation. I've had patients who've come to me who've had it done like in jail, they've had like the top surgery, or incarcerated, they've had top surgery, and not all of the breast tissue was removed. I had an MRI for them, and then I had to go back and remove breast tissue to erase their risk of having breast cancer in the future. The alternative to that would be to have mammograms, despite the fact that they've had mastectomies, just because there's still breast tissue left over. So you have to sort of be vigilant if you've had top surgery. And if you feel like there is like leftover breast tissue there, then you should still be getting mammograms each year.
Good to know, for sure. I think that's really important to
Yeah.
remember that, one, men can get breast cancer. Two, top surgery can still leave breast tissue, right?
Yeah.
Any other thoughts on Dr. Keith's comments and research and thoughts?
I mean, terrifying. And Dr. Candace and Dr. Keith stating those facts is most likely the first time that these individuals are hearing this. And the same way that we are trying to teach young women how to advocate for themselves, we have to kind of guide these individuals as well, how to advocate for themselves, because we can't expect their providers. I mean, I've heard a few times today, once again at this conference, where providers are reassuring these patients who are in transition that they have nothing to worry about. That's not necessarily the case all the time. So you do need to know that you have to advocate for yourself. So please check your breasts.
Yeah. Use some thoughts.
I do. I just think it's so unfortunate, the lack of conversations that are had, not just about kind of the way in which organs are sometimes neglected by the current standards of care because of transitions, but let's just talk about billing and the complications I see day in and day out through both of my parents' work on the administrative side. So creating new diagnostic codes to just go with this, because people have legally changed their gender to male, but require, you know, a hysterectomy. And how does insurance justify a hysterectomy for a male? It's rejected. We're talking about multi-millions of dollars worth of claims, worth of surgery, worth of hours, sometimes for really needed things, for masses that could not possibly stay in the cervix. And the point of all of this is just considering there needs to be an overhaul on more than just the patient level, right? There needs to be a lot of cognitive effort on the queer community's part when you pick your insurance, to make sure you're picking insurance that doesn't make you quote unquote try for 6 months before getting approved for IVF, that doesn't, you know, rule out the ability to have a prostate screening if you are to transition from female to male, or to have a breast cancer screening if you are to transition from female to male. I just think there's so many things to be cognizant about and to be aware of when unfortunately trying to navigate the healthcare industry as a Black person, as a queer person, as a woman, as someone who might be non-binary. And I'm really grateful for your work, Dr. Candace, and grateful for Dr. Keith for bringing it to us and making it something that we are actively thinking about through all these different facets, not just, you know, what happens for some of these preventative screenings, but what happens afterwards. So that's really.
I think it was really important and enlightening the way that you said, like, I think we all know this, but named like, well, now you have like 3 checks against you, right? If you are, you know, Black, gay, like, you know, now you're screwed basically. But, you know, it's like now you just can't, you're not going to find the care that you need. And so I think it's important to acknowledge those as just as big as barriers as those insurance and all the other things that come into play. But yeah, this has been heavy, but like also very enlightening, and invigorating. So it's exciting in that way. But as we kind of begin to come to a close here, I want to ask everyone, like, what can Touch do? What can we do to bring more breast health to the LGBTQIA community, to what can we do differently, right? To like really bring this to the forefront. And I think like you even naming a location where where you found good care is a good start, right? 'Cause I think word of mouth is huge. So like I would advise like asking your friends where they get their care. And you know, that's my best advice. And that's how I've even found doctors that I've liked from friends and recommendations. Like Uza's been like, yo, go see my therapist. Like she's great, like, and it's been like, that's a great way to find doctors that you can trust. But in general, what can Touch do? What can we all do? What can the audience do tomorrow to bring breast health and just health awareness to the LGBTQIA community? Any thoughts?
Well, I personally feel like something that we can do is we can start bringing it more to socials, because now this day and age, we do run to our socials for a source of information. So I feel like we could start sharing it with our friends for them to put it on the socials as well, or putting up flyers or taking it to church homes where you could have those comfortable conversations at.
Yeah, those trusted spaces are great. Isis and I we were doing activating over the weekend with the fam at churches, and it was great.
Yeah.
What else, guys?
I think Dr. Candace helped me realize today that it's not just, checking your tits, you gotta check the bits. So for my friends who have gotten top surgery, for my friends who have definitely been on hormones longer than others, I think that's really important too, is kind of normalizing that not all breasts look the same. Some breasts have been removed, some breasts are regularly binded, and all of those breasts are just as at risk of killing the people we love who have them. And so at the end of the day, whether you love your biddies or not, we still got to check them, and we still got to keep each other safe. So that kind of awareness of like, this is about safety and affirmation, to make sure even the things that we see as aesthetic are reminded that they are not. They have the power to harm us too. That's been a great and sobering thought, Dr. Candace.
Well, that's even good, Jalen, for you to say that, because my mom always says like, check the breasts that you love, right? And I think that's still really relevant, but like, what if you don't love them, right? What if that's like not your experience with your boobs? And so like, even if you don't love them, check them too,
And I think as like a healthcare provider, or any healthcare providers watching, I think it's really important to just remember that we're all human, and to do your best to make all of your patients feel comfortable, because in order to take the best care of your patients, they have to be open with you. Otherwise, like, you won't know things that are going on that you need to know.
Yeah, I love that, Dr. Candace. I remember I had a professor in college who used to love saying, it's okay not to know, but it's not okay not to find out. So it's okay if you have no clue how to address me, but like, let's make that comfortable. How would you like to be addressed? And like I said, open-ended questions versus the yes or no questions. Because I want to know that you actually want to know who I am as a whole. And I think as for Touch, we are trying to be more in the queer spaces. And I'm really excited about that. And then I think Nat said it earlier, for those of us who are feeling more comfortable about being vocal about being queer and Black, for those who may not be there yet, to kind of be the voice for them in a way, but not be their voice exactly, to make them feel more comfortable, the more loud and vocal we are about that, to feel like, okay, I'm not alone in this.
Totally. Well, we're gonna, continue to work on it and figure out a touch. It's definitely a priority. And so visit Love of My Girls for more information. Check out our website. We have a really fun playlist that you can check your girls too. It has, I would say, gender affirming music on it for sure. And yeah, we are here, so reach out if you have any questions as well, because like as you said, if we don't know, we're gonna figure it out. So thank you guys for being here today. This was a great conversation. Happy Pride, and we'll see everybody at all the festivals and all the good stuff. But also, like Jalen said before, like make sure you are intentionally being a part of this movement. So thank you, Black Doctor, and all of our sponsors. Thank you.